Next speaker is Dr. Madhu Uddaraju sir. He needs no special introduction. He is a stalwart in this field of cornea, and he is a pioneer in India who has done among the first cases of minimally invasive approach, including the Bowman's layer transplant. Over to you, sir.
Thank you. Thank you so much, Arjun, for making me part of this program. And I also thank Srini sir for giving me this opportunity to part of this Golden Jubilee celebrations of KSOS. So I think in the next few minutes, I'll try to cover the minimally invasive approach in advanced ectasias, that is keratoconus. So the scope of this topic would be under the following headings. So if you see the trends that are 1 decade trends in the US eye banks, slowly if you see the ectasia, this is the red line, that slowly the things, ectasias requiring transplants are slowly coming down. What is the reason for this? Even if you see here, the number of people who are undergoing anterior lamellar keratoplasty are way less when compared to the people requiring regular PKs, EKs and other grafting. So the reason for this is thanks to the technology that now we have access to, as already Arjun has beautifully covered, the recent topographers that we are having access to with the Steinflug imaging or the ASOCT epithelial layers, and also all these things you can early diagnose the disease quite early. And also cross-linking has definitely changed the way in which we manage keratoconus. So once you have an early identification followed by an early intervention, most of these cases do not progress to a condition that would require a surgical intervention. So if at all there are cases that we have missed and thus have gone into advanced keratoconus, do we have an option of not going into a transplant? Can we evade a transplant somehow? Was the idea which we had tried some procedures. So even scleral lenses previously were quite expensive. They were imported, so they were costing around 1.5 to 2 lakhs to the patient. But now I think after the manufacturing that has started in India by LVP and other companies, the cost of the lenses have considerably come down. And especially now you have the Mini Cooper lenses, that's the 1-fit scleral lenses. They have quite a bit of flexibility. Like you can, most of the advanced cones also, you can definitely have a good cover and they can have a good best corrected visual acuity. Just nothing else, just scleral lenses. If they're having good vision, leave the patient. That's the least invasive thing you can do. And these lenses also, fitting can be seen with slit lamp. And also you can see, as I've shown them, software is available in Sirius and Sirius Plus for this contact lens fitting. That also you can use. These lenses are relatively affordable and they usually last from 3 to 5 years, and a 6-monthly service is done by an optometrist. But you have to have a well-trained optom, and patient education is paramount importance. For the initial trial, you have to spend at least 4 to 5 hours, make the patient wear them, and make them stay back in the hospital at least for 4 to 5 hours. Make sure that the fit is good, the patient is comfortable, and knows how to put the lens on and off. So if you are able to do this perfectly, 80% of the cases you can avoid a transplant altogether. Next are tissue sparing techniques or the less invasive techniques I'm going to tell you. So the black thing is the tissue that we are going. This is previously, all of you know about Intacs. Intacs became less and less popular because of the PMMA material that was used, and there were a lot of extrusions and infections that were associated with it. So thanks to Dr. Susan Jacob from Agarwal's, she developed a corneal allogenic intrastromal rings, that is the KSOS procedure. And we have tried something called as the Bowman's layer transplant that I'll show you in the coming slides. So this is the KSOS procedure that you can observe in the video. So here, like you have your regular trephine, this trephine has a double blade. So it cuts in 2 places. So when you cut a tissue, you get a ring, okay? So that is the ring you are looking at. That ring you separate it into 2 hemispheres, then you spread it out. This is the donor part. So this double trephine is available with Madhu instruments. And in the recipient part, the pockets can be made with a femtosecond laser if you have an access to. Or there is one more instrument from US that you can also manually try to create these pockets. But femto has a better accuracy in doing it. So that is how you insert and you excise the excess tissue out of these pockets. Similar thing you do in the other semicircle. So in this condition, as you are leaving the central part clear, the visual acuity and the correction of cylinders is better, and you can titrate it according to the cone position. So this is the procedure of CARES, and this is how it looks post-operatively. So next is the Bowman's layer transplant. So Bowman's layer transplant, so these are the cases that are not suitable for cross-linking, that they have too low pachymetry. In these cases, you don't want to do a DAL. In these cases, you can try this procedure. So this is the donor preparation. So you mount the donor tissue onto the Barron's chamber and you scrape off the epithelium and you stain the Bowman's layer with the blue. Bowman's layer is usually limited to the central 7.5 to 8 millimeters of the cornea. Like you do your can opener technique, you just give nicks in that area so that you have a plane from which you can start peeling out the Bowman's layer. Ours is not a Bowman's layer standalone technique. We also harvest 100 microns of stroma along with it because we want to add volume into the cornea and make it suitable for cross-linking if required at a later stage. So this is how you create the tunnel with your regular tunnel blade. And just by lifting and putting the tangential pressure, you get a correct plane and the interface will be smoother when you do it in such a way. You can just peel it off once 3/4 of it is complete. So that's the Bowman's layer along with stroma. Now you can refine it to the size you want. Usually we do it from 7 to 8, in between 7, 7.5 to 8, depending upon the location of the cone. And once that refination is done, your donor preparation is there. And you can smoothen out the stromal surface either with a diamond burr or a 15 number blade and make the surface smooth so that you don't have any interface issues. Now coming to the recipient preparation, you mark the central marking of 8 mm so that you can put the donor into that area. First with the with the regular crescent blade you can go. These are the Summerbusak lamellar dissectors that we use in dissect. Same thing you can use in the donor recipient eye, and you can try to create a mid-stromal pocket. You have to be careful in the central part where the thinning will be more. So you have to be gentle in your procedures when you are doing this. So once you create this mid-stromal pocket centrally in the 7.58 millimeter, make sure you hydrate the stroma well and make sure there is no blood or any debris. And once that is done, you introduce a glide and then introduce the Bowman's layer stromal transplant into it. You also can create the stromal pockets using a femtosecond laser if you have an access to it. So once that is done, you can center the graft well and iron out any faults. And that's the end of the surgery, and that is how it looks post-transplant. So I think the main idea of Bowman's layer transplantation is by adding tissue, first you are making this cornea less steeper, you are adding volume. So these patients who are previously intolerant to contact lenses would become tolerant to contact lenses. Most of their higher order aberrations would also come down because you're making the cornea more regular. And so far we have been doing this technique from 2017, and none of the cases so far required a transplantation. Most of them we are managing well with regular contact lens or scleral contact lens. We tried combining with cross-linking in few cases, but the requirement of cross-linking is also very less. That's about it. Any questions in this I can take. Thank you. Right.
So, thank you, sir. That is